Hi everyone, today I'm going to be doing a presentation on obsessive compulsive disorder. So first we have to go over the etiology. So obsessive compulsive disorder has no known cause, but there are many possible causes. And so first we have to look at biology, the brain chemistry and functional differences in the structures of the frontal cortex. Genetics can also be a factor in the development of OCD, though there is no specific gene that has been determined. Personal history is another factor. Some people theorize that obsessions and compulsions are learned behaviors, either from watching others or it's self-taught over time. And then there are several risk factors. So kind of going back to the genetics, family history is a possible factor. So if you have a close family member who has OCD, you're more likely to develop it. Traumatic or stressful experiences can also increase your risk of developing this disorder. Kind of going back to the personal history, kind of when you go through very stressful events, it could cause some of the obsessive and compulsive behaviors after going through something very traumatic in order to try and cope with it. And then also having another mental health disorder puts you at greater risk. So first let's go over what obsessive compulsive disorder is. And it's a psychiatric disorder that is distinguished by repetitive actions, rituals, and troubling thoughts. The presentation of symptoms differs among individuals, but there are common characteristics across the disorder. The DSM-5, which is released by the American Psychiatric Association, sets the measures and standards for OCD diagnosis and definition. The onset of OCD occurs in early adolescence and early adulthood. So going over what obsessions and compulsions are, we'll look at the definitions based on the DSM-5. So obsessions are repeated and consistent thoughts or urges that are unwelcome and invasive, which cause stress and anxiety. Compulsions are defined by repetitive behaviors, and these behaviors are performed to decrease or eliminate distress and anxiety, but they're done excessively. So, some of the main characteristics, as again defined by the DSM-5, in order to have it classified and diagnosed as OCD, we first have to look at the presence of compulsions and or obsessions. Secondly, the obsessions and compulsive behaviors take more than 1 hour a day. So it's not just like a quick thing, it lasts a long time throughout the day. And these obsessions and compulsions create issues with socialization and affect your ability to perform functional and occupational tasks. Third, the compulsion and obsessions are not symptoms of any physiological effects from taking other substances or medication, whether it's something for another medical condition or alcohol abuse or other drug use. And then lastly, these distressing symptoms are not due to another mental health disorder. So you have to rule out other things before OCD can be diagnosed. Here I have a nice visual to kind of show the cycle of symptoms in OCD. So you start out with an obsessive thought that causes distress and anxiety. You have a certain compulsive behavior that you do in order to relieve the anxiety and obsessive thoughts that you have. And again, this is done pervasively, so it's not easy to stop it. It takes over your life and prevents you from kind of doing the things that you either want or need to do. And then down below that little chart is some of the common repetitive behaviors that people with OCD will exhibit, which includes hand washing, placing objects in a specific order, counting, kind of excessive bathing and cleaning, obsessive tapping, and then repeating certain words or actions. So looking at some of the anatomy and physiology involved in OCD, we first have to look at the regulation of neurochemistry in the brain. So it's found that there's kind of an abnormal functioning, releasing, or even with the uptake of serotonin, dopamine, and glutamate. The frontal orbital striatal area and the dorsolateral prefrontal cortex play a role in hampering the ability to functionally plan and organize for people with OCD. And there's also abnormalities with the white matter in the frontal cortex. So the cortical striatal thalamic cortical circuits that connect the orbital frontal cortex, the anterior cingulate, the thalamus, and the basal ganglia. And again, I have a nice visual here that kind of shows kind of the elements involved in terms of the neurobiology in OCD. So you have the different factors that can affect the transmission of these chemical agents in the brain, so the glutamate, the serotonin, and dopamine, that cortical thalamic striatum circuit in the brain, and that dysfunction there that can then lead to the OCD symptoms. So to look at the incident rates and some statistics involved with OCD, first of all, the incident rate for OCD is 2.5 to 3% of the population have OCD. Some people think that it's actually a larger number, so many people don't seek out treatment. They feel ashamed that they're having these certain behaviors, or there's not treatment options available for them to get the help that they need. So the number could be greater, but this is kind of the general incident rate that we have. There's no great statistical difference in the prevalence of OCD based on gender, except for when you look at children. There seems to be more cases of OCD found in boys than in girls. 76% of people with OCD presented with symptoms as children, and in children and adolescents the prevalence rate is 1 to 3% of the population. About 90% of people with OCD have another mental health disorder. It could be depression, anxiety disorder, schizophrenia, or more, kind of going back to that risk factor of if you have OCD, you're likely to have another mental health disorder. So OCD is diagnosed through clinical evaluation using screening tools to first rule out other diagnoses before using the evaluations for OCD. A screening tool for the clinician is the Yale-Brown Obsessive Compulsive Scale, kind of the gold standard to use. It's the most accurate assessment of OCD symptoms with established reliability and validity. The tool can assess 64 compulsive and obsessive characteristics in addition to the severity of them. This scale is also used to kind of see how treatment has affected a person with OCD. So if your rating on this Yale-Brown Obsessive Scale reduces, then you are responding to the treatment. The Obsessive Compulsive Inventory short version is a self-administered tool that can help diagnose OCD. It has 18 items that are scaled from 0 to 4 on the basis of the severity of the stressor, and a score of 21 or greater out of 72 indicates OCD. And then the Florida Obsessive Compulsive Inventory is a short survey based on the Yale-Brown Obsessive Compulsive Scale, and this assessment tool uses a 0 to 5 severity scale on 20 symptoms to detect the presence of OCD. So to treat OCD, first of all, is psychotherapy, and it's found to be the most effective treatment for OCD, with the best evidence practice being cognitive behavioral therapy. And cognitive behavioral therapy is comprised of cognitive restructuring and behavioral interventions. And the behavioral interventions incorporates exposure response prevention, which involves stimulus exposure to bring out the obsessions along with the stressor to work on how to avoid the following compulsions. So basically you're trying to trigger responses to help people learn how to deal with the stressor without doing those compulsive behaviors. Medication can also be used to help manage obsessive and compulsive symptoms. So serotonin reuptake inhibitors are the most common medicine treatment used for OCD, with a reduction in symptom severity of 25 to 35% when used. The first medication used to treat OCD was clomiprazole, which is still used today. Both these medications have shown an efficacy in reducing symptoms, but neither one has really been shown to be better than the other. It kind of seems to be more of what the individual responds to. Alright, so there's also surgical procedures that can be used to treat OCD. It will target the structures in that corticostriatal thalamic cortical circuit that is believed to be responsible for OCD symptoms. Procedures include anterior sigmoidotomy, limbic leucotomy, capsulotomy, and succeedate tracheotomy. And while there is a good response rate in the 6 to 24 months following surgical procedures, there is less evidence of its efficacy, and since it's such an invasive procedure, it's typically just reserved for more severe cases, people who haven't responded to other treatment methods. And there's also deep brain stimulation, which uses surgical implants of electrodes and electronic stimulation to specific areas of the brain. And it is typically used to target the thalamus nucleus, the subthalamic nucleus, and the anterior limb of the internal capsule. And this treatment has been shown to decrease the scores of that Yale-Brown Obsessive Compulsive Scale by about 45.1%. So it does show that it is a good treatment option for people. And then for the prognosis of OCD, it's a chronic disorder in 60 to 70% of cases, and it will continue without treatment, and even with treatment, the symptoms and cycles of OCD symptoms can continue on through that person's life. Recovery and remission are possible with treatment, and the people who seem to have the best outcomes are those who start showing their symptoms later in life. They have a good insight in their behaviors, and then also if they have smaller periods of symptom presentation, so those cycles of obsessive and compulsive behaviors are less common. Their symptoms are also less severe. Typically they have a better outlook on remission and respond better to treatment. Quality of life for people with OCD is greatly affected. The obsessive and compulsive behaviors really impact people's lives and their ability to do everyday things and to live independently, to have a good social life, and even with treatment, that quality of life may not always improve. So treatment isn't always able to get rid of it, and so you kind of have to help them live the best that they can, and that's where OT can definitely come in, is help these people learn how to function in their lives, and even in despite of the difficulties that they have with the obsessive and compulsive behaviors that they have. Alright, so that's all I have for you guys today. There are my references, and I look forward to answering all of your questions.